So today, our objective today will be to review the scope of palliative care that's provided, billing model for palliative care, and we're going to introduce some of our members of our palliative care team. So for palliative care, it's basically care and comfort for the seriously ill. Palliative care provides comfort for individuals living with a serious illness such as cancer, heart disease, lung disease, kidney failure. The purpose of the palliative care is to alleviate any physical symptoms and emotional distress related to the diseases or their medical treatments that they're currently receiving. So our team can see patients in the outpatient clinic. We do have our patient palliative care center, which is on the Avow campus, and we are actually reopening that center September 28th, but we will continue doing some telehealth visits along with in-person home visits as well. So our palliative care team, it's a team approach in the services that we provide. We do the medical collaboration, the psychosocial support, spiritual support, and advanced care planning. Our team is consistent of our nurse practitioner, Lisa Gonzalez, our licensed social worker, Shay Fuller, our chaplain, Marie Talley, and our physician. We actually have Dr. Nearcorn, who is our medical director, and also joining would be Dr. Torres. So one of the things that we talked about in our IDT meeting this past week is what palliative care is not. We're not a sitter service. We're not a service that goes out to the home and draws blood work. We're not private duty that provide nursing or home health aides. We're not a homemaker service or a physical therapy practice. I think sometimes the misconception is that we do all that in our practice, but it is not within our scope. So for consideration for palliative care is very important, and we can actually work together, because when you all are seeing patients, you see you're seeing them for hip fractures, wound care, anything to that sort. But there's also other symptoms that the patient can be experiencing, and you can identify them, or that they may benefit from palliative care. They could be such symptoms as shortness of breath, fatigue, constipation, cancer-related pain, anxiety, depression, or other uncontrolled symptoms. This is where we can work together. When you're seeing someone in the home, you see that they have other symptoms or other chronic illnesses that may be beneficial for palliative care. So then everyone stops and says, okay, so we hear that home health cannot happen at the same time of hospice. Is that true for palliative care? Well, no, not exactly. So working together does not mean that they cannot have both services at the same time. So what's different from hospice services is that palliative care is a fee-for-service structure. We get reimbursed by Medicare Part B. It's more like a physician reimbursement model. So it's just like if, for example, you're in doing care for a patient in their home setting, and they also go see their cardiologist. It's just that it's the same practice. So they could see a palliative care provider at the same time as home health. Medicare and Medicare replacements, Medicaid and private insurance do reimburse our services just as they were a physician model. There's some plans in the Medicare replacement plans that if you were to refer to us, we will need to proceed with an authorization for services, and we do that, and we work together on getting that. We can provide services because we do have different provider numbers, whether different PTANs, different MPIs. And most home health agencies, and correct me if I'm wrong, are reimbursed from Medicare Part A, which is completely different from the fee-for-service side. The one glitch when I called Medicare and I spoke to Deandra at Medicare, I asked her about services, and the only thing that she was very adamant about was that we cannot duplicate services. So what came to mind was licensed social workers, because I know some agencies, home health agencies, do have social workers on their team, and so do we. So we would have to collaborate and just confirm if your social worker is providing service. If not, then the referral can be made to our licensed social worker. So there are several things. Medicare is not real straightforward on what the benefits are of working, having both services. One of the disclaimers they say when you call them and try to ask them to guide you to a CMS manual, they say we do not explain or show people how to bill, but we do answer questions. That's what the disclaimer they gave me. So when I asked them about working together, if a Medicare patient needed home health care and also wanted to receive palliative care, I was told by the Medicare provider representative that yes, the beneficiary can obtain both services. So I think that's one of the things that is questioned about having both services. It's kind of muddy the way that Medicare says it, but we will work together and always try to collaborate and for the benefit of the patients. So we have, this is a very short session. It was more, we wanted to set it up more as a roundtable discussion. So I'm going to open it up now to introduce Lisa Gonzalez, our nurse practitioner in palliative care, to have her explain what her role is and what services she provides through the palliative care program. Lisa?
Hello, everyone. So nice to have you guys join us for this presentation. Simply, palliative care, in my role as a nurse practitioner, I am managing symptoms. So it's not symptoms for someone who has just back pain. It's the patient who is suffering from a life-limiting illness, if you can kind of hone in on that. So my oncology doctors are prescribing, the referral, or sending the referral in. Why? Not for me to really address the cancer, but to manage the symptoms. What symptoms? Pain, nausea, loss of appetite. But sometimes it's just to talk about their anxiety about their cancer. They don't have any pain, they don't have any nausea. And that is my role, to discuss that. And then I tie in Shay, our social worker at MSW. So that's the value of palliative care for oncology. But let's say I get a referral from pulmonology. There's a patient, COPD, on oxygen, sees her pulmonologist every 3 months, pretty much stable, but she keeps on going in and out of the hospital. And now my pulmonologist is thinking, I don't have any other tools in my box, Lisa. Is there something else you can add? In that scenario, I'm ordering maybe some Ativan, a benzo, to relax them when they feel very dyspneic, or I'm ordering liquid morphine, or I am just talking about the big picture and we start talking about advanced directives and what are their wishes if they should have an event that requires CPR. So then I'm obtaining a DNR. And we're having a very long discussion about that before it gets signed. But the pulmonologist is hoping that I could get that done because he knows there would be no value for intubation in an end-stage COPD patient. So my role with pulmonology and even cardiology is to talk about the big picture. I want to just express that referring palliative care doesn't mean, oh no, you have 6 months or less, or oh no, that's just a doorway to hospice. It really is to just allow the patient to voice goals of care and how they want things to occur if they should decline. So not all the time am I managing symptoms. I'm also talking about goals of care and talking about end of life issues. Sometimes it's just a one-time consultation just to get this all wrapped up, and then they can call me if they need me. They never see me again. And as a patient, let's say Medicare patient, it's an 80-20% model. So 80% Medicare pays, 20% is their responsibility. Sometimes secondaries pick that up. Sometimes that's their cost. And then they don't see me. But then they'll call me 4 months later and say, guess what? I was back in the hospital. I think I need to talk to you about that. So we can have that model, or my cancer patients who I see every 2 to 3 weeks because I'm managing a whole bunch of symptoms. But so I want you to understand that as long as you guys are thinking, wow, this is somebody who has a life-limiting illness, it's appropriate to think about palliative care, even if I just see them one time. If you have any questions about it, let's say, oh, I'm not really sure if this person is even palliative care appropriate patient, you can always call the office. I call people at the end of my day, and this has happened many times where I collaborate with you and let you know if it's appropriate or not. I'm here for you guys. I know it's really difficult to understand the 2 different programs, but please don't be shy. Call me and we can work it out. All right. I think I'll leave it to Shay to speak about her role, and then we'll open up to questions.
Hey everybody. So yeah, my name is Shay Fuller. I am a social worker in palliative care. I will tell you I'm pretty new myself to palliative care, so I'm learning alongside some of you also. So it appears that the majority of the patients I can see really do need some kind of, they need to have, unfortunately, some kind of anxiety or depression or ongoing mental illness, which could be long-standing or it could be short and new based on them having medical struggles. Not everybody. I can see other patients that don't have some anxiety or depression, but that really has to be the focus of a lot of my time with patients, is sort of from a therapeutic standpoint. I can provide other things such as resources or do Medicaid applications and things like that. But as far as Medicare reimbursements criteria for palliative social work, it's pretty narrow. And Rebecca, please step in and correct me if I'm wrong with saying anything, because again, I'm still learning too. But you know, I have come from the hospice side of social work, where we can do a lot. We can do a lot for patients, and in the scope of palliative, it is really focused on psychotherapy support. I do want to reiterate also, like Lisa said, that, you know, a lot of our patients are kind of hospice eligible. And for me, coming from hospice, I think, you know, I would love to have them get that support from hospice because it's such a great program. But we also have to respect and understand that their wishes are very, very different, very different. And so what we're doing is offering support along their own journey of getting aggressive treatment. But just because someone's hospice eligible, of course, doesn't mean that they want to do that, which we 100% respect. So I would say that that's a little bit of the role of social work. I work with Lisa. I give her information. She gives me information about people that may need one of our services. But for the most part, most of the patients we see do have both Lisa and I involved in their care. There are several that only see nurse practitioner because they don't have an emotional component. They don't need social work or want social work for that psychotherapy support. And then similarly, I have patients that I see for psychosocial support that Lisa does not see because medically there's nothing that she's treating for them. So we do have a team approach, and we do work in accordance with that team approach, but we do meet individual needs based on what we're seeing they're needing. So Rebecca, was all that correct?
Did an awesome job. Thank you so very much.
Thank you.
Hey, did you want to say, or Lisa, how we do spiritual support with Marie? Because Marie wasn't able to join us today.
Yeah, I would like to, Lisa, if you don't mind. First, Chaplain Marie, she's the newest to the team. So my understanding is that chaplain services are not billable, but we do want to offer that support to families. I just met with a family last week that had it was a lady that was really expressing to me, why is this happening? Why do I have this disease when I did everything right in my life? And on top of that, this person can't make it to church anymore. So, you know, chaplain services were offered, and we'll continue to see if that's something that the family would want. yeah, so she's going to serve a great purpose for palliative care.
Yeah, I'd like to add also, sometimes patients tell me, well, I'm not religious, I'm not into that. But we have a patient this week that Marie is going to see who just came out of the hospital. And she's elderly, she's 94, and she's going to see her. And I think it's going to be a wonderful visit. So you don't have to be religious to accept a visit from Chaplain Marie. She doesn't have to go there. You know what I mean by that. Just giving that spiritual support and saying, good for you, you got out of the hospital and I'm here for you, really goes a long way. So I agree with you, Shay. It's going to be a wonderful addition.
Great. Thank you, Lisa and Shay. So, so you heard about what our program consists of, who our team members are, and how we can work together to benefit your patients, our patients. I know that sometimes Lisa has made referrals to home health services. And so we can really work together and provide the care and support that patients need, whether they're in the home or whether they're, in a facility. We can really do services really much wherever a patient is really at their home. We just need to make sure that they meet the criteria on the Medicare guidelines. But we are able to work together and provide that support not only for your services, but also any support that the patient and their family needs. As you heard, our team consists of several different disciplines. So I'm going to open it up now for any questions. And Mark, I'm not sure if you can see the chat, if there is a chat, if anyone has questions in the chat, or if anybody wants to just go ahead and say, hey, I have a question. Please feel free to now.
So far, I don't see anything in the chat, Rebecca.
Okay.
I do just want to say one other thing about the interactions and the team approach that Palliative will have with home health agencies. Just last week, I met with one of our patients, and we felt that he would need home health for several different reasons. He would have been eligible for physical therapy. He needed a social worker to see him more regularly, possibly some nurse oversight. And so I think Lisa and I understand that you all have, as home health agencies, your own criteria for seeing patients. Unfortunately, what happened during that visit was he said, no, the home health person said, no, Avow is what he needs. He doesn't need home health, he needs Avow. And I said, he's not on hospice. He's on palliative care. It's a different program. It is not the oversight like a case management weekly nursing visit setup, which would also be available in hospice. But I think that he was just very confused on why the gentleman was not on hospice. And the fact of the matter was he doesn't want hospice. So I think that that's an obstacle probably for home health agencies, is to have an understanding of which side is the patient on with Avow. Is it hospice or is it palliative? And how would we best give you that information?
So Mark, I don't see any questions. I don't see if you see any questions. Our presentation, like I said at the beginning, was short, more of a round table. But if there's anything that we could help with, if you identify anybody that you think may benefit, our contact information is up on the screen. You can give the center, or the Palliative Care Center, a call, and we'll be happy to work together with you and try to see what benefit we can give to the patient's care.
All right, well, thank you,
I'd
Rebecca.
like to add one more thing, guys. It's Lisa Gonzalez, nurse practitioner. I know I talked a lot about oncology patients, cardiac and pulmonary patients, but we have a big population of dementia patients, especially here in Southwest Florida. And with that population, if you guys can identify, if you see any behavioral disturbances, which are very frequent with our dementia patients, that's another appropriate palliative care patient, because I would manage those symptoms of sundowning and offer a lot of support to the family who feels overwhelmed. So it doesn't have to be the patient that's losing weight. Our dementia patients actually aren't losing weight. They're eating a lot of ice cream at night. So, but they do have the sundowning, and that would be appropriate for me to address. And also in that scenario, discuss advanced directives. It's important to do that because our dementia patients, when they get admitted to the hospital, really do have an escalation of delirium, and we want to avoid that. So discussing advanced directives with the family is paramount. So just wanted to focus on those kind of things. Our Parkinson's patients, they are big fall risks. So that's another important referral so that I can educate about fall risk and progression of disease. So it's not always just the cancer and cardiopulmonary. It's those neurogenic disorders that you should just be mindful of. And once again, if you have any questions, you can reach out to me and we can talk about it, and then you can refer, okay?
Thanks. Do you have any last comments before we wrap up the meeting?
I actually have a question for Lisa. Lisa, can you take us through maybe a scenario, and you could pick exactly what type of patient, but how do you identify when a person may be ready to go from palliative care to hospice? And you know,
Yeah, that's
and
a
how
good
do you,
question. So it's pretty easy with my oncology patients. I always tell them when their oncologist has that conversation that it doesn't look like the scan is showing any improvement. It doesn't look like you're tolerating oncology treatments. I think maybe we should pause. All that terminology is really an open door for me to talk about the hospice services. And it's just, you know, just talking about it. No one really has to feel that they have to go on to hospice services, but usually by then my cancer patients don't feel well and they realize that it's time to transition. My end stage cardiopulmonary patients, it's when they're tired of going to the hospital. So they have these exacerbations. And then once again, I talk about goals of care, listen to what they have to say, what the family has to say, the fears that they have. And usually they also decide, I don't want to go to the hospital anymore. And then that's the reason to get hospice involved. For my dementia patients, it's this escalation of behavioral disturbances. The family just cannot cope anymore. They're a nervous wreck. No one is sleeping at night. And usually I get that phone call and we talk again about goals of care. And if, you know, it's appropriate, we talk about hospice services. With my Parkinson's patients who are falling all the time and maybe at one point had a femur fracture, hip fracture, that opens up the conversation. Possibly we need to talk about hospice. So what's important is to start palliative care as early as possible. Believe me, I am not going to discuss hospice over and over again. On the first visit, I do explain to the patient and the family the difference between hospice and palliative care. And then after that, I am a palliative care specialist, and my focus is to provide symptom management, relieve suffering from my patients, and keep them educated about their disease. I am not here to judge or make any decisions for them. I'm just here to be by their side while they go down this journey. I think that's it.
Thank you, Mark, for having us join you all today. And thank you for everyone who joined us today.
Thank you. Thank
You're
everyone.
welcome. Bye, guys.